Hello, I'm Dr. Wayne Halstrom, inventor of the silencer. This program has been designed to give you the information you need to fit the silencer appliance. It will also prepare you so that you may become certified to provide silencer therapy for the treatment of sleep apnea and snoring. Chapter 1 discusses snoring and its relationship to sleep apnea, which is a potentially lethal medical disorder. Chapter 2 details the causes and consequences of snoring and sleep apnea with an analysis of some treatment alternatives. Chapter 3 introduces the silencer. Chapter 4 details the technique with particular emphasis on obtaining a precise bite registration. Chapter 5 covers the fitting of a silencer and patient instructions. Chapter 6 discusses some case management and troubleshooting. Please watch this video all the way through and then complete the certification quiz. More detailed information is available in the Silencer Handbook. We are very pleased that you have decided to add the silencer to the services you offer in your practice. It is certain to be a boon to you and to your patients.
In the last 25 years, there have been major advances in the study and treatment of sleep disorders. Sleep disorders are now understood to be definable medical conditions which are linked to many physical and psychological ailments. The most common sleep disorder is snoring. One of the most worrisome is sleep apnea. These conditions are almost always linked. To many, snoring may merely be an annoying social problem or a subject for humor, but at its worst, snoring may be an indicator of sleep apnea. Studies in the U.S. suggest that just over 40% of middle-aged men and nearly 30% of middle-aged women are habitual snorers. And after age 60, these numbers climb to 60% for males and 40% for females. Snoring, even without apnea, can lead to numerous arousals during the night from obstructed breathing. And arousals have been shown to produce sympathetic nervous system activation. Snoring is also associated with an increased risk of hypertension, as well as an increased risk of both cardiovascular and cerebrovascular disease. In fact, apnea sufferers have 2 to 3 times the risk factor for cardiovascular disease and twice the risk for stroke. Sleep apnea is a condition in which, at numerous times during the night, the sleeper stops breathing for short periods. There are several distinct types of sleep apnea. Obstructive sleep apnea, or OSA, is defined as the cessation of airflow for at least 10 seconds due to recurrent upper airway closure, despite ongoing respiratory efforts. Central apnea is defined as the cessation of airflow for at least 10 seconds associated with a decrease in respiratory effort. Mixed apnea is a combination of obstructive and central apnea. It begins as central apnea but is quickly followed by chest and abdominal movement with upper airway obstruction. Hypopnea is a 50% decrease in airflow associated with a decrease in respiratory effort for at least 10 seconds. An hypopnea incident has occurred when the blood oxygen level drops by an amount greater than 4%. Obstructive sleep apnea syndrome, or OSAS, is defined as symptomatic OSA. Many people have apneas during sleep which are not pathological and do not produce any obvious symptoms or consequences. It is when apnea is frequent that symptoms generally result. Sleep apnea is often misdiagnosed as narcolepsy, which is a rare form of recurrent and sudden onset of sleep. Usually, significant OSA is defined as more than 5 apneas per hour of sleep or greater than 15 hypopneas per hour of sleep. Approximately 17% of male habitual snorers and 7% of female habitual snorers exhibit significant OSA. Patients suffering from OSAS don't spend sufficient time in REM sleep. REM stands for rapid eye movement. During this phase of sleep, only 2 sets of muscles are active: the orbital muscles of the eyes and the muscles of the diaphragm. Because OSAS sufferers don't get enough REM sleep, they don't receive the restorative and regenerative qualities of sleep. There are a number of risk factors for obstructive sleep apnea. OSA is 8 times more common in men than in women. However, the prevalence of OSA increases in women once they pass menopause. Obesity is also an extremely important risk factor. Craniofacial abnormalities such as facial trauma, retrognathia, and micrognathia are important, particularly in thin patients. Sedative or hypnotic drug use and alcohol intake cause relaxation of the upper airway muscles and increase the likelihood of upper airway obstruction. There may be a genetic predisposition. A person who has a first-degree relative with OSA runs a 30% risk of also having OSA. Diagnosis of OSA is made on the basis of an appropriate history and physical examination and overnight polysomnography. Overnight studies can take place at a hospital or sleep clinic or in the home. All decisions relative to the determination of the appropriate sleep study fall under medical case management. As such, they should be made by the patient's physician or sleep specialist. Treatment plans can then be coordinated with the patient's physician and dentist. The majority of patients with OSA present with a history of loud, chronic snoring associated with a combination of witnessed nocturnal apneas, unrefreshing sleep, and daytime sleepiness. Because of the persistence of their symptoms, many people come to accept excessive daytime sleepiness as normal. Nocturia, decreased libido, and morning headache are common complaints. Other symptoms include poor memory, irritability, and poor concentration.
There were times when she'd have to poke me to see if I was still breathing, because I did have an indication of sleep apnea where I'd actually cease breathing, and I wasn't aware of this.
And I would lay there and I'd count 1, 2, 3, 4, and then I'd go and punch him sort of to see if he was going to be breathing again. And of course he'd go like this and he'd start breathing right away.
The cessation of breathing, I believe, hastened my heart problems. Certainly I was very young. I was only 46 when I had the double bypass operation.
We discovered I was unable to stay awake for any length of time during daytime, which was had some embarrassing features to it, particularly when you're working in an office. I'd fall asleep while I was talking on the telephone, or I'd be dictating a letter and I found myself falling asleep in front of my secretary.
The noise level of sleeping with a snorer of someone like my husband makes it impossible. It's almost as loud as a pneumatic drill when your head is that close to someone else's on a pillow.
Well, my motivation for seeking treatment was that I started to develop a fairly significant snoring problem. Wasn't as much a problem for me as it was for my wife. You know, she would constantly have to wake me during the night in order for her to be able to sleep. And it started off just an occasional, once a week, once every couple of weeks. And as time went along, I became a much more regular snorer. And so I started looking for answers.
What I understand it to be is a fusion of the vertebra, and X-rays show mine to be fused from C1 to C6. And that the hairline is low, and that the neck is short. And that's my understanding of the Klippel-Feil, along with the limited neck movements. The symptoms I had that were most troubling were falling asleep at night and waking to gasp for air, or not being able to fall asleep and seeming to need air, having to actually sit right up in bed or sit over the edge of the bed. A terrific amount of nighttime breathing problems.
The most problematic symptom that I had with my snoring and sleep apnea problem was morning headaches. I used to wake up in the morning and have a headache, and as a matter of fact, in the course of the night I'd have a headache. I'd wake up in the morning and I would have this headache, which would last an hour or two after I got up, and then it would disappear.
Well, it's something I'm proud of, but then again it's something I'm not proud of. I've been in the Guinness Book of Records for 4 years, from 1990 to 93, as the world's loudest snorer. It's a dubious title to have. I went to my family doctor. My family doctor referred me to the University of British Columbia Sleep Disorder Clinic, and there they wired me up with bells and whistles all over my body and tested me out. And they just couldn't believe the horrendous noise that was coming through and the severe sleep apnea I had.